Sorry about this. So, even as a general ophthalmologist, we should know what is the anatomy of the peripheral retina. We have the pars plana and we have the ora serrata, and we have the vitreous brace which straddles the ora serrata into the pars plana. There are various vitreous adhesions which are there, which are physiological and pathological. You can have adhesions to the peripheral retinal lesions. You can have vitreomacular traction and adhesion to the periretinal blood vessels. Now the question arises as to what are true flashes and what are not. So flashes of light are pinprick spots of light that you see in your field of vision. Suddenly you will see something blinking over here, going off, blinking over here, going off. So these flashes of light in your vision come from inside the eye. They are not caused by outside lights or anything else outside your body. And the flashes of light usually appear and then fade away quickly. Now this is a very important thing. They fade away quickly in a matter of about a few seconds, at the most 10 seconds or 15 seconds. Why do these flashes occur? They occur because of stimulation of the retinal photoreceptors by the traction of the vitreous gel. So this is very important to remember. Now these are sometimes people have described them as pinpricks, spots of light, shooting stars or lightning streaks. Many of your patients say that it starts from here, goes around. So these are all basically flashes of light. This can be exacerbated by coughing or Valsalva maneuver. Sometimes you get up in the middle of the night coughing away, you may see some flashes of light in your periphery. They can happen because of trauma, because of stimulation of the photoreceptors. They can sometimes happen because of severe rubbing of the eyes also. And sometimes in some patients even saccades, that just movement of the eyes can trigger off these flashes. So true flashes, what are they? True flashes are basically because of stimulation of the retinal photoreceptors because of traction of the vitreous gel. So this typically happens in patients with a PVD, in which changes in the vitreous gel causes a change in the consistency. The vitreous gel becomes liquid and separates from the retina. You can also have flashes associated with a retinal detachment, proliferative diabetic retinopathy because there can be pull on the retina because of the scar tissue, and retinal tear. Also because of vitreomacular traction. Flashes of light can occur because of various other conditions also, like choroidal neovascular membranes, cytomegalovirus virus retinitis, torn retina, migraine, PVD, Stickler syndrome, etc. Now, what are not true flashes? In a migraine patient, you have flashes because of constriction of the blood vessels. They are not directly because of stimulation of the photoreceptors. And these are sensory symptoms that can occur. Migraine aura is some symptoms which can happen before or after the headache. Now, in the contrast, what happens is that these occur as zigzag lines. They may be colorful. And typically, the patient can say that I don't see vision in a particular field. This basically happens because of migraine, because of spasm of the blood vessels. Here you can see this red and green and yellow lights which are there in a zigzag fashion. This is the way a typical patient with migraine will present to you. And these are not because of pull on the retina, which we are most worried about. Then you can have something called as pseudo flashes which happen after cataract surgery. This is seen because of reflections due to new lens. If you have a lens with a very high refractive index, then when light shines on the eye in a particular way, you can have suddenly a streak of light which goes. Or in some of these newer lenses which are there, the patient complains of a cutoff of this vision and a circular flash kind of thing. And this typically happens in the left eye. God knows why it happens in the left eye, but that's the way it's been described. It happens more in the left eye than the right eye. Then you can have glare. This glare can be because of high refractive index IOLs, which is described as light streaks. It is also described as starbursts due to black backscatter of the light. It can be again because of light scars due to the light arcs because of edge of the IOL and rings and halos. Now this is taken from cataract coach. If you can see over here, these are various things which are described by the patient as a flash, but these are not true flashes or true floaters. These are just halos around the light, the way it's been described. Even here, if you just see through your windshield, if you are driving in the night, if you see through your windshield, you see that each of these light has a scatter around it. This is a normal patient with a normal car windshield. And sometimes these are also misinterpreted by the patient as a flash. Here you can have a patient again with the affected vision. Over here, because of some of the lenses, you can see it like this. Now a dry eye can exacerbate all these symptoms. So you may have a patient who's just done cataract surgery, and because of any of this phenomenon, along with a dry eye, he suddenly starts seeing more flashes of light. And sometimes just putting a couple of drops of methyl cellulose or something can reduce these flashes. Then sometimes flashes can happen after LASIK surgery. This is when the LASIK cup is applied and the suction is induced. At that time, there can be stimulation of the photoreceptors and patient can get flashes. And usually, again, these flashes go away. But it is also important to remember that these flashes can be associated with a retinal tear in some of these patients because many of these patients are high myopes. Then, how do you differentiate between retinal cause, migraine, and halos? In a retinal cause, the flashes appear and disappear quickly. In migraine, you have zigzag lines, bright spots, which can happen with or without aura, and sometimes you can have a headache. Now, what are alarming signs? If you have a sudden increase in flashes or floaters, that is a very different alarming sign. You have to examine these patients immediately. And as Dr. Vatsal Parekh said, you have to examine both eyes of these patients. As retinal surgeons, very often we see that patient has PVD in one eye. There's no lesion in that eye, but in the other eye has had a retinal tear because of a PVD about 3 months ago, and that tear has been missed. So in such a case, we need to treat the other eye with a laser. You also have to remember that if an area of visual field has got cut off, then it could be a retinal detachment. I think some of these things Drashti has already taken, so I think we'll go a little fast on this. So when a patient complains of black spots without flashes or floaters, how would you examine? You have to examine both eyes of the patient. Now sometimes you have a streak hemorrhage in this patient, the patient is having flashes. You examine the patient has no tear. What do? The first thing I would do is ask the patient to wait outside, examine him 5 minutes later again. Because if there's a small streak hemorrhage, very often there's a chance that I have missed a break. So I would like to examine that patient 5 or 10 minutes later, fully dilated, again see the patient, and maybe you can find a small break somewhere. So this is something which is extremely important. So it's important to know that flashes and floaters require a detailed vitreoretinal examination to rule that out. Now, how would you manage an acute PVD? I think Drashti has already explained already most of the things. You have to have a dilated examination. The high-risk features are blood obscuring the details. Again, I repeat, if there is blood, there has to be a tear in 95% of patients. So if you're not finding a tear, examine again, and again. Okay, here you have a small thing which is a floater over here with flash, and as we said, how do you examine? Again, it's very important that you have to examine the patient with an indirect ophthalmoscope with scleral depression. Direct ophthalmoscope, you can only see the posterior pole, nothing more than that. You don't have binocular vision, so you have to have an indirect ophthalmoscope, dilate the pupils, and examine the patient with scleral depression. Many of these fancy equipments which are there, which are wide field fundus cameras do not show you 100% of the retina. They show you about 80 to 90% of the retina, but in that remaining 10%, you may have a tear which is there, and hence just a fundus picture with a wide field camera is not enough. In all patients with flashes and floaters, you have to have indirect examination with scleral depression. Again, here you can see multiple pigmentation over here. And there can be various types of tears which are there. Here you can see again a tear over here. Here you can see tear at the posterior pole. Again, this will give rise to a flash because of traction over here. Again, there's a tear, a horseshoe tear over here, which will give rise to flashes of light. So in all these patients, you have to be careful. The risk factors: RD in fellow eye, family history, cataract or YAG laser. If your patient complains of flashes or floaters after the YAG laser, be sure your PVD has been induced. Dilate the patient and have a look at it. There can be symptomatic tears, traction on the edge of the tears, the location of tears, and fluid around the edge. Here you can see large tear which has been completely lasered off. Now, if you can if you see this picture over here, this is the posterior pole picture. Looks normal. What does it show? It's absolutely normal. But look at this part over here. This is what you will see in a direct ophthalmoscope, or just a fundus picture. Here you can see a little bit of abnormality. You go to that area and you can see a superior retinal detachment. So if you see it with a direct ophthalmoscope, you're only examining this part. You're telling the patient, go home. But that's not true. You are missing a retinal detachment. So hence, I repeat, you have to do an indirect ophthalmoscopy with a scleral depression. So in some of these patients, we need to do B scan. And to conclude, the most important thing is that the patient you have to do patient counseling. You have to have realistic expectations on these patients. You have to tell the patient if your flashes are increasing, your floaters are increasing, you have to come back again, and we have to do a repeat examination, maybe once every 3 days, once every week also if possible, till the time you are sure that there is no tear in this patient. Thank you.
Thank you, Ashish, for a wonderful presentation. Dr. Ashish Vaidya is a senior vitreoretinal surgeon in Mumbai. Uh, One thing which all comprehensive ophthalmologists in fact, you can detect the possibility of a tear apart from the points which Ashish highlighted on history taking. Uh, uh, when you look at the patient on the slit lamp, and if you find tobacco dusting in the anterior vitreous, there's a very high chance that this eye has got one or more retinal tears. So look at those eyes extremely carefully. Another scenario is post YAG capsulotomy. Post YAG capsulotomy, different studies report rates of 2% to 40% of retinal tears. So after doing a YAG capsulotomy, please call the patient back, not only for a glass appointment but also to look at the retina with dilatation and with indirect ophthalmoscopy with scleral depression.